Mondo, hello world, hola mundo, hello monde. We're here today in Brussels with Professor Jean-Louis Vincent at the 2015 edition of the ISICEM. So Jean-Louis, what's new this year at the ISICEM?
Oh, many new things, my good friend. A lot of negative studies. That's how we have the batch say yes to intensive care medicine, because we had the results of the third study on early goal-directed therapy, negative. Well, another negative study, which is not bad, is the age of the blood. You know, younger blood or fresh blood is not necessarily better than somewhat older blood, which is reassuring for the blood banks at least. And then we have, SARS is dead. Nobody speaks about SARS anymore. We go back to sepsis being a bad infection. And then we had some excellent things from Professor Ronco on renal replacement therapy, of course. So a lot of new things.
Well, but at the basic, let's say, speculation, we go back to the philosophy again of personalized medicine.
Absolutely.
I think that we have to make sure that a negative trial is not preventing us from doing intervention, right?
Absolutely.
So what is your point of view from that?
No, I fully agree, because in all these trials you have heterogeneous patient populations. The results show no difference between one arm and the other, but there are potentially some patients who were benefiting from the intervention, but others who may have been harmed by the intervention. And so globally there is no difference, but there may be individual cases. So you are very right. We need to go into personalized medicine, and it's not because we have a huge trial of thousands of patients that we find the truth necessarily.
And I will present, in fact, today the same concept that if the patient is too sick or the patient is not sick enough, maybe the intervention will not be effective. But in a specific time window or severity window, we can actually be beneficial for the patient. So this is a message for young fellows. Please look at your patients, look at the severity, visit your patient, know the literature, and then undertake specific intervention based on the seizure and, let's say, a very important knowledge of the field.
Yeah, it's very important. I mean, we cannot do whatever we like. We need to base our decisions on what we know, and this is from the literature, preclinical, clinical data, and also some consensus opinion. It still has a place to know what the experts think based on all these elements. So it's important to do the things right, but it's not based only on large prospective randomized controlled trials looking at mortality.
Halfway between opinion, halfway between large evidence-based trial. With this, I thank you very much for joining today, Cappuccino from Brussels, and enjoy yourself.
Excellent. Excellent.